I'm going to talk about something slightly different, and that's what is going on at bargaining tables across the province and a little bit across the country as well, because of the situation that we are all familiar with, which is the increasing cost of drugs, both because of price and utilization, and the fact that this is pushing up premiums. This is something that's having an impact on employer-employee relations and is certainly a subject of increased tension at bargaining tables. So we all know that patient advocacy groups play quite a significant role in educating the public about drugs, in to some extent shaping public opinion. We don't very often think about the role that unions play on the drug scene, and for reasons that I'm not going to go into, but in BC, 36% of employees in BC are covered by employer-sponsored benefits. That doesn't include their families and spouses. A majority of those people are union members, but in spite of that, they're overlooked as key players in this question. The whole area of collective bargaining shifted quite significantly during the 1970s, and because of that, bargaining benefits became much more important and much more of a central focus in discussions between unions and employers because of wage controls and basically because of the shifting of the downloading of costs from federal to provincial governments and from provincial governments to private payers. Since 2000, at least, and probably much sooner than that even, employers have been pushing back at the bargaining table. There has been an increased move by employers to, in response to higher premiums, they have been also wanting to increase the deductibles and co-pays paid by employees. A lot of people are being eliminated from benefit plans, and that is true particularly with retirees. And there's been a cost shifting in terms of flexible benefits and different types of plans, health savings accounts and so forth and so on. But there are also a lot of innovative approaches to this. So it's not all cost reduction and so forth and so on. A lot of unions and a lot of employers are trying to come to grips with what's going on. In 2005, for example, the auto workers and the auto industry adopted a conditional formulary. This was really on the cutting edge within the unionized workforce. And so now CAW members have to get special authority for brand name drugs. The Canadian Union of Postal Workers and Canada Post have initiated 2 pilot projects, which I think that they're ongoing. One of them is funded by Health Canada to fund herbal products to treat stress. So that was one of my favorite ones. But also looking at alternative therapies for chronic back pain, which is one of the problems that is experienced frequently by letter carriers. Union members have had mixed responses to this. I mean, union members are no different from anybody else. They get their information from all of the same sources as the general public does. And so they have initially looked at this move with some skepticism, I have to say. But they're also in a bargaining climate which has really deteriorated over the last number of years. Employers are feeling the pressure because of rising premiums. Wage increases have been stagnant for the last decade at least. Unionized workers feel that their backs are against the wall and that health benefits are the last refuge, the last place that they can feel that they're not being subjected to takeaways and concessions and so forth and so on. It's in this climate that employers, particularly in the public sector, are coming to bargaining tables with a proposal for a Pharmacare managed formulary. So what we're looking at, so these are this is the background to what's going on. We have these incredibly rising drug costs. followed by rising premiums in response to drug costs, but you can see that the average annual wage increases are really, really way down, and of course a lot of these costs are above the consumer price index. So union negotiators are looking at this picture just as much as employers are. The EHC, the extended health benefits, this is a projection from Mercer. These projections are scary, for everybody. 80% of the health benefit package, 70 to 80% across the country, is going to drugs, as opposed to Pacific Blue Cross, which is 64% of the cost of the benefit package is for drug costs. And Pacific Blue Cross, of course, is tightly linked to the Pharmacare formulary. A lot of this is leading to one thing, and that is an actual decline in the number of employees in Canada who are covered by employer-sponsored benefits. This is a reason why we need a national Pharmacare program. The reduction in coverage is not consistent across the population. If you are a high-earning, educated male, you are the most likely to be covered by private drug benefits. If you are a female working in the retail sector and below the age of 30, you are so less likely to have health benefits. BC, as I said, has one of the lowest rates of coverage in the country, probably because we have a very small public sector, one of the smallest public sectors in the country as well. So again, we have this push for this growing interest in the Pharmacare formulary and a much more tightly managed formulary. There's been mixed responses. My colleague and I have done a number of focus groups with union members, and there is there's initially a really high level of skepticism. Unions themselves, although there's some support for going in this direction, there's also a lot of concern and uncertainty. And these are some of the sources of the uncertainty. The doctor-patient relationship is sacrosanct, and nobody has a right to interfere with that relationship, including with the prescribing patterns that are used by doctors. So this is seen as something that the employer, the unions, and the government should just stay out of this arena altogether. And there's not a very good understanding of actually what influences prescribing practices and what positive role a formulary can have on prescribing practices. There's also just a prevailing belief that the newer the better, and that it's also no coincidence that the newer drugs are the most expensive drugs usually. There's an association in the minds of union members that safe and effective is associated with the newest drugs. So that's something that's really, really deeply embedded, just like it is in the general public. Old is associated with less safe and less effective drugs, and Pharmacare and employers are pushing old drugs for one reason, and that's because they're cheaper. So this is the mindset of people when the issue of a Pharmacare formulary comes onto the table for discussion. The third thing is consumer choice, and it isn't just choosing the newer drugs, it's having the most choice, and commercial formularies have more drugs on them, more newer drugs and more drugs generally. And so that is seen as, that's a real point of contention. Why should we go with the Pharmacare formulary when it has fewer drugs? We can have all these other options, and so it is seen as a concession, actually, to the employer to move towards a Pharmacare formulary. From my perspective, the problem isn't the lack of choice, it's the lack of informed choice amongst the public and union members included. So, from my perspective, one of the things that Pharmacare really needs to do is undertake more public education. The pharmaceutical industry is really focused on education. They fund patient advocacy groups, which undertake education of their members and have an impact on public perceptions. They are funding clinical practice guidelines through patient advocacy groups. Pharmacare needs to do something else. They need to really begin engaging with the public on why a managed formulary is safer and why the drugs on the managed formulary are effective and safe. I think that Pharmacare also needs to advocate very vigorously in favor of informed choice rather than against choice. I think that people need to be supported. Consumers are not stupid people, and if they have the information that they need to make an informed choice, they will most likely make a better choice. The last thing is that there is no independent patient advocacy in Canada that has the same level of attention and the same boom as pharma-funded groups, and there has to be a consideration of public funding for independent advocacy. Unions also have a responsibility. They have to educate themselves. The people who go to the bargaining table have to educate themselves. The employer is coming to the bargaining table. It's not a level playing field at that table. Employers have consultants that advise them about how to approach drug benefit costs and health insurance rising premiums, etc. Unions don't have that information. They don't even have access to the formulary. They don't know what's on the formulary, and if they do get the formulary, they usually don't get the data that they need to be able to strengthen their hand at the bargaining table so that they can bargain intelligently about what's going on there. Unions also have to educate their members, because if they don't, they can, the negotiators and the union leadership can embrace the Pharmacare formulary, but if their members aren't with them, the members will dump that leadership, and that's just a plain fact. Those people go to a convention every year and confront their members on issues precisely like this. So there's a real need for education within the trade union movement as well. All of this, in my mind, leads to the issue of a national Pharmacare program. We so need this in Canada for all the reasons that have already been mentioned. Within the labor movement, there is very, very strong support for a national Pharmacare program and a national formulary. And they are undertaking campaigns, they're initiating education amongst their members in support of a national Pharmacare program. There's also strong support amongst the provinces for a national formulary, and there are steps being taken for example, with bulk purchasing and so forth and so on. But the main thing is that there has to be greater outreach to the public by governments, by the provinces, and by public drug plans. Thank you.